regional anesthesia under general anesthesia. And my interest in this topic started with this patient that I met. And he was a 47-year-old gentleman who had Huntington's chorea. And he had continuous active coriform movements and intractable shoulder pain. And nobody would give him a shoulder replacement. Nobody would perform the surgery because they thought that his underlying illness would prevent healing and would disrupt the repair. We talked to the wife, who happened to have been a geneticist, interestingly enough, the surgeon, the patient, and we said that we will do this for you, but it's going to require us veering from what we consider standard of practice. Needless to say, he had a general anesthetic with a rapid sequence induction. He had a beautiful, well-placed ultrasound-guided continuous interscalene nerve block, an uneventful shoulder replacement, and for 48 hours, he was able to move his hand but had no choriotoid motion of his shoulders. So I went back to look at the data. Have people really been doing this even though we've been saying we shouldn't? And I found this study from 2005. It was a retrospective study in a private practice, 548 patients for arthroscopic shoulder surgery. They all received GIO with an LMA. They all had a 22-gauge stimulated nerve block. You can see the agents they had. They had 24 hours in the hospital, and they were all assessed up to 2 months after surgery, and they had 0% long-term sequela. The point of this is that all of these blocks took a caudad direction when they were placed. In a more recent prospective analysis of interscalene blocks under general anesthesia, this group looked at 910 patients, again using a nerve stimulator technique. They noted that they had a minimal resistance to injection when they placed their block. They used aspirations. And their patients logged symptoms for every 48 hours. All the patients were seen at 10 days, and the complications were followed to a minimum of 6 months. Basically, what they found were that the success rates and the complications of ISB with general anesthesia were similar to those that are performed in awake patients. The problem with this study is that they did have 8 complications lasting more than 6 months, but they never were able to separate, or they never sought to separate what was surgical in nature from what was anesthetic in nature. We saw this study this morning, 1,000 ultrasound-guided peripheral nerve blocks, a prospective study. We saw that there were 6 patients that had problems at 6 months, and anybody that was had a nerve injury after 6 months, the complications had a clear etiology unrelated to the nerve block. But what we didn't see this morning when we looked at that is that 32 of these blocks were performed under general anesthesia, and that was not a statistically significant factor for complications. And when we look at that 7,100 peripheral nerve block study, which I think we also saw this morning, if you look closely, 15% were sedated and 23% were unresponsive. When they said unresponsive, it was general anesthesia. It also included patients that had femoral nerve blocks placed with a spinal anesthetic on board. And again, we saw that in that study that there were very few complications and none that were directly attributable or in this discussion that the sedation level made any difference on our patients. We just had a lovely discussion about pediatric regional anesthesia, and I could have grabbed one of any of a zillion papers talking about regional anesthesia performed under general anesthesia, but I picked this one because there were almost 30,000 patients that had regional anesthesia with general anesthesia going. And what they found in their almost 5,000 plus patients that had upper and lower limb blocks were included in the 175 complications. Most of the complications were in central blocks. Of those 175, 134 were even deemed not reasonable to call a complication. They were positive test dose, urinary retention, but there were 41 complications in 40 patients. Most of them occurred in the operating room. They were high spinals. They were seizures. None of these patients had sequela after a year. And this truly supports that we can, what our last speaker said, perform general anesthesia with regional anesthesia in children. So, if we've seen prospective studies, we've seen retrospective studies, we've seen children, why am I standing up here debating this incredibly handsome man? Because in 2000, John Venomoff told us of 4 patients that had terrible anesthetics. They all had interscalene blocks performed under general anesthesia with techniques that would make your toes curl. They used long needles. They had responses at high currents. And in fact, all of these patients ended up with syrinx. They all had intracord injections with permanent neurologic sequela. So he gave us these rules that we've been living by. General anesthesia is a relative contraindication for ISB. Don't use large needles. The needles should have a caudad direction. He told us, because we didn't know already, that obese patients have obscure landmarks. But he said, ensure the patient does not unexpectedly move. I know a really good way to do that. General anesthesia. So, my colleague is going to get up here, and he's going to brilliantly argue that if you put your patients off to sleep, you're going to lose the warning signs of LAST, and patients can't report pain from errant needle replacement. And I'm going to say, pooey. First of all, GA may in fact be protective from LAST because every one of the agents that we use in fact increases the seizure threshold. Maybe if we did all of our blocks under general anesthesia, we would actually decrease the incidence of local anesthetic systemic toxicity. Test doses may in certain patients be more reliable than them reporting symptoms. This little child who had an epidural and had a dose placed in, had a caudal for lower extremity surgery. Beautiful, nothing's here. After the injection of their epinephrine test dose, we see evidence of peak T waves. This child's tachycardia wouldn't have helped us. It's only the good use of the test dose to report symptoms. So we don't really always need a patient awake to tell us that something is amiss. And although I use this as a bad example on my last talk, I'm going to say that now that we have ultrasound, we really can decrease our doses of local anesthesia. So maybe we will be seeing decreased incidence of LAST with these new lower dose blocks. You know I'm going to tell you that a patient can't tell you if they have a needle intraneurally. And you know it is. Great study. One of the favorite studies that I tell every resident, everybody who says to me, what's going on here? Happened to cross this park from me at St. Luke's Roosevelt. They took 24 patients who were going to have a popliteal block for foot and ankle surgery. The endpoints of their study were either a stimulation, as we would expect, between 0.2 or 0.4 milliamps, or the needle was seen in the nerve. It was really interesting, but in the 20 of 24 patients, there was no stim received until the needle was seen in the nerve. And in those last 4 patients, the needle was in the nerve visualized, and the stim was all the way up to 1.5 milliamps, and still no stim was gotten. So all of these patients, all 24, actually had needles in their nerves at some point. They told us that the absence of stimulation doesn't preclude intraneural injections, and it may lead to unnecessary attempts at localization. None of these patients had neurologic sequelae from their intraneural blocks, and all of them were awake during their surgery. But being asleep wouldn't have helped, wouldn't have made a difference. And of course, our beautiful hostess today, our session moderator, taught us that patients can't even tell when you're sitting on their nerve and banging on it. And again, she looked at 102 patients having axillary blocks. You could see very minimal sedation was used during this study. And she banged and banged and banged, and only 34% of these patients would, 38% of these patients were able to perceive a paresthesia in an awake state. So what good is keeping a patient awake if they can't even tell a paresthesia is occurring or that you're having needle nerve contact? They're not going to help you being awake. Okay, think of what we've really been doing all along. And things are better because with ultrasound, we're now minimizing our neural trauma. And when we used to do pop blocks, as I mentioned yesterday, everybody looked like they had buckshot on the back of their leg. You would go in and out and in and out in a sawtooth pattern looking for a stim when half the time you were probably in the nerve and just not getting your stimulation. So if you are able to do regional anesthesia with general anesthesia, you do exactly what Benimoff requested of us. You decrease the chance of sudden movements. You certainly increase patient acceptance. And you increase the number of patients who can benefit from our really useful interventions. Pediatric patients, which we spoke about, patients with developmental delay or dementia, all can benefit from regional anesthesia where you would never get near them in an awake situation. The way some of my colleagues do their sedation anyway, it's not much different from giving your patient a general anesthetic. If you push some fentanyl and you push 4 milligrams of midazolam or whatever you're going to use, and they don't know what hit them, is it any different than putting an LMA in them and having a controlled airway? I argue there's no difference. But now we're stuck with this big, white elephant in the room. It's the ISURA Practice Advisory on Neurologic Complications in Regional Anesthesia and Pain Medicine, which was written in October 2008. And from that Benimoff article all those years ago, they state interscalene blocks should not be placed in any anesthetized patient. They do note that ultrasound-guided blocks and pressure monitoring are new, and they say that the recommendations may change with data and experience. And I'm here to tell you that since those were published, there have been over 1,000 index publications talking about nerve blocks, ultrasound. It's all there in the literature for our review. I also question the authors of this practice advisory because it really makes no sense to me to say that a practice of performing interscalene blocks in an adult is totally unsafe, where it's an acceptable way to practice in a child. I mean, it inherently doesn't make any sense to me anyway. So even though this is what's there for us to guide, I have issues with what they were looking at when they made them and their conclusions. We have this beautiful tool, ultrasound. It does decrease the risk of intravascular injections. It allows the decreased volume of agents. I lost a slide. Let's back up for 1 sec. I switched a slide because actually, if you go to Regional Anesthesia and Pain Medicine this week, and you look at your e-published papers prior to publication, there's a paper by Brian Seitz, and it looks at 12,600, sue me if I missed a couple hundred, prospective interscalene peripheral nerve blocks that are ultrasound guided. And in this group of 12,000 plus patients, there was 1 incidence of LAST. So now we're finally seeing numbers that show that our use of ultrasound may decrease the incidence. Continuous visualization can prevent catastrophic events and certainly avoid intraspinal cord injections that we saw in those ridiculous cases before. And I'm going to say to you that ultrasound blocks are different from nerve stimulation and paresthesia blocks. The paper this morning that Dr. Perlis chose to show us as one of the most important that she felt in the last few years, this actually is the accompanying editorial to it, where we reviewed the article and said that, are we comparing apples to oranges? Do the data that we get from older papers really, are they valid today? And again, somebody earlier this week mentioned, when I started my career, I wouldn't do a supraclavicular block if it was the only choice I had. My technique of walking off the first rib and then moving my needle towards the nerves, either eliciting a paresthesia or a stimulation, if I was wrong, the next place my needle went was clearly in the lungs. And people were quoting 6+% incidence of pneumothorax from this block. This supraclavicular block that I spent 25 years swearing I would never do is now my go-to block for everything. Because we still have a supraclavicular block, our needle is still above the clavicle, but the whole block, the way we present it, the way our needle travels, is a totally different block. So when we look at data and meta-analyses of older papers for supraclavicular blocks then versus supraclavicular blocks, ultrasound has really made it a whole new world of practice for us. So in conclusion, we have been absolutely deluding ourselves thinking that keeping our patients awake will prevent neurologic complications. What we need to do, as you've heard all weekend, is meticulous attention to techniques to prevent our complications. We know that ultrasound guidance is the most successful method of nerve localization we have to date. And the combination of ultrasound technique with this nerve stimulation and general anesthesia, the combination of ultrasound with general anesthesia will permit the performance of regional anesthesia in everybody safely and allow us to expand our patients that we can help. So thank you very much.